Hello, everyone. My name's Alex Graves. I'm the Director of Technology here at Lyft. I want to thank everyone for joining us for Lyft Upstream Interventions, our webinar series, and we're really excited to have everyone here for this session titled Poverty as a Health Crisis, Economic Mobility, Coaching as a Healthcare Intervention. I'm just going to go over some quick housekeeping here at the top. If you need live captions on the meeting, it is available. So to use the live captions, go into the upper right corner, click that More button, go to Language and Speech, and turn on live captions. And to turn them off, follow that same process to turn them off. You'll want to select English for the spoken language when prompted, so that it can follow along with our speakers, as that's going to be the primary language during this webinar. So having said that, welcome again. I'll pass it along to Lyft's CEO, Michelle Roan Collins, to get us kicked off. There you go, Michelle.
Thank you so much, Alex. Welcome, everyone. It is wonderful to see everyone gathered today, and I'm so excited to be opening the second webinar in Lyft's Upstream Intervention series. We have new friends and old gathered, so for some brief background, Lyft's mission is to break the cycle of poverty by investing in parents with young children, and we do this by providing financial, employment, and educational coaching to nearly 1,000 families nationwide. Through our model, we put parents in the driver's seat, providing caring and dignified support as they work to achieve their own goals. Goals like going back to school or pursuing a career, opening a business, or making informed and therefore empowered financial decisions. We also give cash to Lyft members to rebound in crises that inevitably arise because of life, or to invest in their dreams so they can become a reality. And we place a premium on opportunities for social connection, as we know that social capital, or put plainly, relationships, accelerates access to financial capital. Folks, this is an investment of hope, money, and love. That is a radical response to foundational hate, bigotry, and wealth stripping practice and policy that has created widening race and gender wealth gaps. And this humanistic approach works. Last fiscal year, we saw our members increasing their incomes by over $20,000, increasing their savings by $4,000, and decreasing their debt by almost $3,000. But as we work to change lives, we recognize that to address the problem at the root for the millions of families in poverty across the country, we have to change systems. We envision a day when they are also operating with hope, money, and love as the North Star. So we've scaled our model by advocating for policies that increase access to cash and reduce the bandwidth tax on parents, while ensuring that they have a seat at the table in the very policies that impact their lives. Excuse me, sorry, my headphones fell out. And we also achieve scale through our technical assistance programs, where we teach system players on how to change practice by integrating economic mobility coaching into their work in order to improve outcomes. Early on in my tenure at Lyft, I was struck by a conversation that I had with a colleague in the medical profession who was doing some upstream work. And he shared with me the spike in emergency room visits at the end of the month that was directly correlated with food stamps and other benefits that allow access to healthy food running out. It was made clear to me that poverty is a public health crisis. It is a life and death issue, as we actually experienced during the pandemic, with both mobility and morbidity rates determined by zip code, racial background, and gender. And that upstream interventions like increasing financial stability would not only increase health outcomes, but also be less expensive on the healthcare system and highly impactful. So when I met Dr. Adam Chickendance in 2015, it was through a colleague at the Magnolia Place Community Initiative in LA when Lyft had just began to codify financial coaching as a core part of our 2-gen model. And he was interested in studying the well-being outcomes of economic mobility coaching and ultimately embedding it into the pediatric healthcare setting. Together, We did pioneering work that established the benefit of partnership with nonprofits to address social determinants of health and planted the early seeds for the medical financial partnership model. Under LIFT-LA's leadership of Ali Olson, our medical financial partnership took root at Harvard Clinic and blossomed with Dr. Monique Holguin bringing in her expertise in integrated healthcare models to the team. Since then, Lyft has partnered with Dr. Dance and Dr. Holguin to bring Lyft's model into pediatric and prenatal offices. It is worth noting that this body of work also set the stage, thanks to Ali's vision, for Lyft's robust technical assistance within other sectors to influence broader systemic change. Today, we're excited to share with you our seminal partnership that has resulted in a recent study published in Pediatrics. Our hope is that we can use what we have learned today to expand our collective toolboxes with strategies to increase family well-being and economic mobility through cross-sector partnership that, like our work with Lyft members, is founded in relationship and trust. We will first hear from Dr. Dance and Dr. Holguin, practicing clinicians and researchers at UCLA, who will provide more context and share their study findings. Ali Olson will then join on in a panel conversation moderated by Amanda Feinstein, who, in addition to founding Oakland's Brilliant Babies and bringing Lyft's model into the Harlem Children's Zone, has spent her career working to end poverty and promote wealth-building opportunities for under-resourced communities. Before we begin, just a note to please keep the chat function live and in full effect, and add any reactions and questions that you might have for our panel and presenters, and we'll share your questions with the panelists during the Q&A portion. So with that, it is my pleasure to hand over the presentation to Dr. Dance and Dr. Holguin.
Thank you. What a welcome. Wow. We are so excited to be here to share the work we've been partnering with Lyft on for the last 6 years. And so we wanted to start today by sharing, and thank you for the framing, Michelle. I think it's just so incredibly critical that we start the presentation today by first framing the grave nature of the problem at hand. Let's make no mistake about it. Childhood poverty is a major health crisis. We know that income predicts life expectancy strongly, with a roughly 10 to 15-year difference in the life expectancy between those in the highest percentile of income compared to those in the lowest percentile. Child poverty is associated with a roughly 3-fold increase in overall morbidity. So this is a life and death situation. We also know that chronic diseases that contribute to overall mortality, such as obesity, asthma, and a number of other conditions relative to children are also seeing that 3-fold increase relative to children living in middle-income households. And there are a huge number of other examples within nearly every specific disease process across the life course and in different medical specialty practices. So poverty kills. It's a primary driver and inextricably tied to structural racism. Both combined are compounded and continue the grave consequence of continued racial health inequities. And yet we rarely name it in healthcare spaces, and we rarely talk about it. And we rarely talk about the healthcare system's role in it, our own accountability as providers in it, and how we can work together to really improve and the immense opportunity we have if we were to target financial health as an intervention in these healthcare spaces, the opportunity we have to promote overall health and well-being. So against this landscape, the American Academy of Pediatrics in 2016 recommended that pediatricians consider poverty itself as a health issue within our lane as clinicians who care and advocate for kids and families. Soon after, the American Academy of Family Physicians followed suit, and the American Public Health Association for a long time has been ringing the alarm bells to name poverty as a health crisis, as a public health crisis for decades. What the AAP statement didn't specify was how pediatricians and other stakeholders should respond to poverty. when it comes to how it could affect their patients and communities, and what to do about how to build that connection within these healthcare spaces. And so that recommendation was really the driver for us to turn our attention to really build a medical financial partnership. Next slide, please. And so turning to our medical financial partnership in 2017, we were really interested in what kinds of financial support services the families here at Harbor UCLA, we're here at the second largest medical center that serves a large swath of the pediatric primary care population in LA County. We're very interested in trying to understand the families here receiving care for their children. Were they interested in any of the following services listed in this bar chart as part of their child's care? And we were surprised at just how interested they were. Roughly 3/4 of the parents were interested in one or more of these services, and half or more of the parents were interested in any one service individually. So that was a true light bulb moment for us, because it signaled that where parents were in their thinking was they knew that financial stress, financial burden was inextricably tied, intertwined with their children's health and their own overall health. And they already saw that connection, and it was up to us as providers and care team members to catch up. And so health and finances were inseparable. And we continue to hear this directly from the parents we have the good fortune of supporting and walking with over and over again throughout the years. Next slide, please. And this is really exciting. It's exciting in terms of the national landscape. There is a, sorry, next slide, please. Thank you. No, one more slide. Are we still on the slide that, okay, a few slides back, one slide over.
We can speak to it while we get to the one that has the headlines.
It's the one that starts with medical financial partnership impact, and we're happy to speak to it too. I think just suffice to say that there is a growing national conversation and movement with the evidence to match in support of this type of approach, this type of intervention. And we wanted to just offer up, when the slide appears, a few samples of some of the publications and press that medical financial partnerships have received, with noting our recent publication, thank you, Michelle, too, in the Journal of Pediatrics and the corresponding NPR interview. Now, I'm so pleased to turn it over to my good friend and the other co-director, Dr. Adam Shikadance, to share more about the impact of our work.
Thanks, Dr. Holguin. And yes, so you see there the Pediatrics journal article with the title at the bottom and some of the coverage that we got on National Public Radio for this study, which was the first of its kind, evaluating the health impact and healthcare utilization impact of a model like ours, the Medical Financial Partnership. So next slide, we'll talk about what the main findings of that article were and why it made a bit of a splash. So in the next slide, we'll show some of the findings on reducing no-show rates. And the upshot here, and kind of some of the story behind it, is that one of the very first impacts that we noticed early on in the course of MFP program implementation and the randomized evaluation of our intervention was that families seemed to make it to their pediatric primary care visits much more consistently when they were receiving that program, the financial resilience coaching intervention, compared to those families that were in the comparison group, other families in the same clinic who weren't receiving financial coaching. And sure enough, when we looked at no-show rates in the pre-pandemic period, right, this is all from the pre-pandemic period in the pilot and the study that was published, before clinic scheduling got scrambled during COVID, what we saw was that financial resilience coaching improved no-show rates such that there were half the number of no-show rates in the intervention group compared to the randomized comparison group over that critical 2-month to 6-month well-child visit range where children receive a number of pediatric primary care visits and a number of really important healthcare interventions like the vaccinations that we'll talk about in the next slide. And on average, over the course of that first 6 months period for this group of families that all had young children in infancy and early childhood, on average, those who are receiving the financial resilience coaching missed half a visit on average fewer compared to the comparison group over the course of those first 6 months of life. I'm happy to share our slides, which we have here, if that would be helpful.
That would be good.
Okay. Here, let's see. Unless others are seeing the slides and that we're not seeing.
Can we do a quick check-in? Are others able to see slides?
No slides. Okay, let me, I can take down the share and put it back up here.
Okay.
Thank you, everyone. Just bear with us here.
Sure.
Okay.
So it was really striking. We found this difference in no-show rates such that, again, there were fewer no-show rates in the intervention group compared to controls. And on a per visit basis, we saw that families were just under 20% more likely to attend each preventative care visit in that early childhood range in the intervention group compared to the comparison group of families. That's substantial. There really aren't many other interventions that have been shown to increase rates of retention in pediatric primary care to that extent, especially in the critical early childhood period. This, by the way, is a clinical outcome that has gained increasing importance, especially now that we're seeing in the post-pandemic period a number of vaccination rates that are going down and more disruptions in continuity of primary care for families nationwide, really. So getting families into clinic and pediatric primary care so they can gain all the benefits of that care delivery and the health promotion services that it offers is really important. Let's go to the next slide. One of those really cornerstone benefits of attending well child visits early in life is completion of critically important vaccinations that have prevented, over decades, serious illness and death for countless children. And what we saw in our intervention pilot study that we're talking about is that the increased attendance at those early well child visits led to one and a half fewer missed vaccinations in the intervention group relative to controls by roughly 6 months of child age on average. And in the intervention group, the children were 25% more likely to be fully vaccinated at the end of that first year of life. So really substantial benefits in terms of protection against some of the most serious illnesses that we've been able to prevent through pediatric vaccination. Let's go to the next slide. As we mentioned, this is those two initial findings from the pilot study that were published in the Pediatrics journal. Those were early findings from a broader randomized clinical trial that that was ongoing when the study was published. And from the very beginning of that trial, our goal was to understand the broad health impact of this intervention, the medical financial partnership intervention. And one major goal of the MFP ultimately was to impact health overall, self-rated health through structural and economic supports. And sure enough, when looking at our primary study outcomes in the full group of the randomized trial participants, nearly 400 families, half in the intervention group of medical financial partnership receipt and half in the comparison group. When we looked at the primary study outcome of parent overall health status, so how they rated their own physical and mental health, this is an outcome called health-related quality of life, and it's measured in our study using the National Institutes of Health's flagship patient-reported measure of a health-related quality of life that correlates with overall mortality and hospitalizations and a host of chronic illness conditions. What we saw was that parents in the intervention group compared to controls, and that's what this graph shows, parents in the intervention group compared to controls showed a relative improvement of roughly a quarter standard deviation in that score by 6 months post-enrollment. And that score remained higher, improved in the intervention group relative to controls by 6 months post-enrollment into the program. Both of those differences were quite significant statistically. Next slide will show some related findings. So this measure of overall health status, self-reported overall health status, can be taken apart into a mental health component and a physical health component, subscales that measure each of those domains of health. And while even the physical health subscale did show some improvement in the intervention group relative to controls, the main driver that we saw in overall self-rated health improvement in the parents receiving the financial coaching program was seen in the mental health subscale, which primarily measures anxiety and depression symptomatology, including subclinical symptom burden that doesn't necessarily have to be at the level of a major diagnosable mood disorder, but can still be very impactful for parent mental health. And in this mental health domain measure, parents in the intervention group showed a relative improvement again, compared to the comparison group of about a quarter standard deviation compared to controls, comparison group families by 6 months after enrollment into the program, and that improvement was maintained and even extended a bit by 12 months into the program. We were really delighted to see this quantitative evaluation demonstrating what we were seeing, with families in the program already. And because we'd heard for years from parents that addressing their goals and supporting their self-efficacy and their financial stability in their parenting roles had a big impact on their stress and mental health. Not to mention the fact that the care coordination activities that the coaches were participating in the healthcare system meant that intervention families were also more likely to get connected to mental health services when they needed it and in a timely fashion. So I'm going to pass it back to my co-director partner, Dr. Holguin, for the next slide and talking about our model and how it's evolved.
That's great. Thank you, Adam. And I think this is a great transition because through those rich findings, our model, as it should, if we are going to continue to prioritize where parents truly are, it needs to evolve. And we've evolved immensely. And so we want to share a visual representation of how our transformation model has really blossomed into a clinically integrated care, parent-centered, parent-driven transformation model that's grounded in community-partnered principles to directly address the structural root causes of child and family poverty and promote early relational health development. We optimize pediatric visits in infancy and in the first years of a child's life. At its core, the MFP model is built on the trusted relationship between parents of newborns and their resilience coach. A coach's role is to focus on the core parent supports that promote parent and child relational health, development, and well-being by reaching families exactly where they are in those PEDS visits, where they can champion family voice and choice and promote key protective factors, including parenting strengths, supports, critical resources at critical times, and asset building to, again, promote the bond, the healthy attachment and relationship building that we have an opportunity to invest in through the pediatric space and disrupt cycles of material and social scarcity that get in the way of building those bonds through that partnership with both in between the coach and the parent, but also in conjunction. And this is where it's so critical for us, that care coordination, to get the full buy-in and adoption by the care team. And so there's true interdisciplinary cross-sector care approach to this work and this intervention. Our MFP coaches are rigorously trained in economic mobility coaching, thanks in large partnership to LIFT and its mission to continue to disrupt cycles of poverty by promoting and supporting and championing resilience coaching. And they are also trained in integrated healthcare systems, early relational health, community partnership building, and cross-sector navigation. This approach emphasizes a care process that is really centered on high quality care, quality improvement through multidisciplinary care coordination to improve efficient care team communications, saving patients and parents time, valuable time, and also us as providers time, really integrating the parent voice within the healthcare system and in the health record. And we'll talk about that in a minute. so that the parent voice is truly named and prioritized within this healthcare continuum. The MFP is embedded in a teaching clinic. We're in a teaching hospital. The pediatric residents receive focused training and immersion in the approach of population health, and through the opportunity that Adam and I have as faculty to support pediatric residents and other care team members and promote economic determinants of health and drivers and how to address new interventions, upstream interventions that they can optimize within the course of their provision of care to support these conversations. Over the last several years, we have had the opportunity to scale our care model and expand MFP services to prenatal and family medicine clinics. Through this expansion, we have been able to offer our MFP intervention starting even earlier in the life course, engaging with our patients coming in for prenatal care and optimizing this critical time period that can come with a full array of emotions, everything from excitement to anxiety to a number of stressors, priorities, experiences, feelings, life, and of course, financial stressors. And so we are just fully committed to really adopting a life course health intervention that promotes financial health even earlier, that can continue on from prenatal, in the prenatal phase, and bridging into pediatrics, supporting that, using that valuable coaching relationship to be the connective tissue into the pediatric space, meaning that the coach can offer those core parent supports starting in prenatal appointments, and then will continue to be the same coach, that same trusted relationship into pediatrics, thereby offering the true continued care that so many parents and families have deserved for so long and did not have. I'm going to now turn it over to Adam to share more about the opportunities that still lie before us.
Thanks, Dr. Holguin. So you heard from Dr. Holguin sort of how we've evolved even since the period from early on in implementation of the medical financial partnership that was evaluated through the study that was published recently. And we're continuing to evolve. And we're really excited about the opportunities that we have to continue to scale the medical financial partnership and its investment in children and families for population health improvement, developing more tools and resources, partnerships to reach more patients and health systems. And here in the slide, we have listed a few of the next steps that we envision that I think we'll dive into in the Q&A to a large extent. So just want to thank everyone for your interest in this work that we're all doing together through the partnership, and look forward to our Q&A. So I'll pass it back over to Amanda Feinstein, and who will lead us in the Q&A session.
Thank you so much, Dr. Schickendanz and Dr. Holguin. This work that you all are leading at UCLA Harbor is incredibly powerful, incredibly path-breaking, and very exciting to be here with you to dive into it a bit more. I just also want to remind folks that we have the chat available. If you want to put some of your questions in there after my questions, we'll have somebody sort a few, and we'll hopefully be able to cover those as well. Before we get too much further, I also want to immediately, with my first question, bring Allie Olson into this conversation. Allie's the executive director of LIFT in Los Angeles. Allie, I know that this medical financial partnership that your organization has built with UCLA Harbor has become a very central part of the work of LIFT. Can you talk about how the partnership is so innovative, why it's critical, and why this moment in the life of a family when a new baby joins them, comes into the family, is such a pivotal time to make this intervention?
Yeah, awesome. Thanks, Amanda, for the question. Thanks, Dr. Holguin and Dr. Schickendanz for the amazing presentation. We're just so grateful for this partnership. I would start by saying there's a couple points I think that make this partnership really unique and critical. And then to your point around this moment in time, for me, I think this is a partnership that really looks at upstream interventions. That's 2Gen in the approach. So really looking at early intervention, because we know that early childhood and early parenthood are vulnerable periods for families. when they're sort of both most at risk for poverty, and when that toxic stress of poverty is most devastating for the long-term health of children. And because it is a critical development period for families, it presents a timely moment for an intervention that can actually have large multi-generational effects. We know in data that if you can actually increase a parent's income by just $3,000, you increase that child's earning potential by 17%, which then means that we're helping to improve that child's outcomes later in life. But despite that, we know that, as Monique and Dr. Adams said, that oftentimes we're not addressing those issues in the healthcare space. And so the moment in time that early parenthood presents, it's the moment the light bulb goes off, right? Oftentimes in a parent, it's that moment when you start to think about, how am I going to afford childcare? What does the cost of diapers look like? How am I going to care for this small other being? What's my employment going to look like? How am I going to have stable housing? And so it's leveraging that moment where those stressors increase, but then that motivation equally increases, right? There's a recognition that you're not just doing it for yourself, but there becomes a motivator for doing it for someone else. The other two things that I would just quickly name is that there's alignment between the work that Dr. Shikadance and Dr. Holguin are doing, and sort of alignment around LIFT's model about removing barriers to access resources. So how do we create systems of care and access to supports and resources for families that align with the daily rhythm of a parent's life, right? How do we sort of make it easier to meet them where they are, where there's already built-in trust? And we know that pediatric healthcare systems are reaching 90% of families with young children. And as someone who has a young child, in those first 2 years of life, you're going every 3 weeks to see your pediatrician for their baby well visit. How do we leverage those moments and those systems to resource families? And then lastly, the last thing I would just name is that what makes this partnership unique is the values alignment. We can't undervalue the fact that both Dr. Shikadance and Dr. Holguin and the MFP and LIFT, our partnership and our models are rooted in trust. They're rooted in relationship and dignity. They're parent-centered, parent-driven. We see parents as experts in their lives, and that we want to leverage their lived experiences to sort of help us evolve in the way that we're delivering services for them, so that we can be doing the very best to help them break that cycle of poverty. So those would be a couple of the things I would just name. Hopefully that answers the question.
That's great. Thank you so much. So, and it's also a good segue to my next question, which is, clearly large medical institutions and public health systems are a very different beast than nonprofits. And this is a partnership between a nonprofit LIFT and a big public health system in Los Angeles. I wonder if all three of you could say a bit about kind of what are the critical elements of success to these types of partnerships. I think Ali spoke a little bit about the secret sauce for your particular partnership. I'm happy to hear, you may want to elaborate on that as well.
I'm happy to jump in and get us started. I just want to echo everything Ali just shared. And one point that she made was really incredibly salient to answering this question in our minds is this aligned values. And I think keeping that alive is really important. We're 6 years into this relationship. And so to keep a very robust, authentic, core aligning relationship that centers on parents' voice and choice, a strengths-based approach that dignifies parents and families in any space, whether that be in the community or in their clinic visit, that needs to have a parallel process. So that also happens within our own relationship, and keeping those open communication lines, really understanding everyone's perspective and how we continue to evolve the work, coming together to find and create new points of alignment, and how the alignment can translate into opportunities is really exciting, and holding each other accountable. I think, the learnings that we've been able to garner from community partners like LIFT that are really central to the mission to really understanding the realities and the lived experience and expertise of the parents and families, because they are serving within the community, and how we can take that learning and really humble ourselves within these healthcare spaces, and how we can also share, what we've learned along the way in these healthcare spaces. I think that's really core, that parallel relationship that's reflective of the core values themselves. What would you say, Adam?
Yeah, the relationships are everything. I mean, we talk about the relationship being the intervention when we're talking about how the impact of the program, and at every level, the investment in those relationships is what leads to success, which entails communication and coordination, and just lifting each other up all the way through, and recognizing that we come with different skill sets and different perspectives that are all really valuable in understanding how we can deliver a service that serves families better, and optimally. And then, I think we'll get to this in later questions too, but it's just worth emphasizing that we're always led by what the parents are telling us is working, is not working, or they wish they'd see more of in the clinic, and in the program itself, the MFP program itself. And that, that is our North Star, and I think a huge key to our success, and will continue to be. Allie, anything you'd add to those things?
Yeah, I mean, I want to make sure we have time for other thoughts, but the other two things I would add to what's already been said is just the importance of intersectionality. We can't talk about poverty without talking about health. We can't talk about health without talking about poverty. And too often our systems are literally designed in a way that are not integrated, right? And are not holistic, and are not rooted in seeing people as full human beings, and rooted in listening, to better understand what is actually happening in a person's life. I still think back, Dr. Adam, to the example you give of a baby coming in with seizures, and doctors are going to solve for that seizure. But in reality, maybe that baby's having seizures because a mom is stretching their formula that month. And if we don't solve for the mother's struggle to make ends meet month to month, who was desperately trying to show up for her child and probably working multiple jobs, we're not actually solving the root cause of what that is symptomatic is the seizure, but we're not solving for the root cause. And so the more that we can be working collectively together to listening, to actually seeing the whole person, that's super important in the way that we're addressing this issue. And then the last thing I would say is, in addition to sort of values alignment, communication is a spirit of learning, right? I think there's a curiosity and a learning that's a part of this body of work. It's not a coincidence that we're in a learning teaching hospital in this case, right? That has allowed for a lot of this evolution of this work, and a desire to continue to learn how to better show up and serve families in the best way possible.
Thank you all. That's great. It's actually also a great segue into diving a little more deeply into family voice. And I'm curious to have you talk about, practically speaking, how do you integrate the individual and collective experiences of parents and what they have to say about the program into your design and operations?
Really appreciate that question. I'm happy to jump into it, and so excited to be able to answer practically how we've been able to prioritize parent voice. Is we have begun to pilot and embed what we call a parent voice note. And this is after years of using the data to drive the care model that we have now, and learning from parents, as Adam said, directly, learning from parents that they want more voice and choice within the clinic care process. And so this parent voice note that we have been able to co-create with our parent leaders, we have a parent leader group that we'll share more about, as well as the care team, is essentially meant to be a strengths-based tool, a document that's embedded in the electronic health record that is meant to be viewed and reviewed and held accountable by the care team. as well as being driven by the parent themselves. The first section identifies, using the Imagine Parent framework, identifies the hopes, the dreams, the vision that a new parent will have once they have their child. So we use that in the course of the first intake appointment. We sit down with parents individually, and using that beautiful, trusting, resilience coaching relationship, we begin to ask, to set the framing, to shift the narrative that goes from one that may be thinking about risking in to offering up and deepening the conversation to really understand from the parent's perspective, what is your vision long-term for your family? And then using that initial really important question that is often not asked to then ask, what's getting in the way of that? So that we learn directly from parents, what are your stressors? What are the barriers, both acute as well as long-term? And in that, to keep it very culturally humble in its lens and its landscape, we center on trying to understand parenting practices, the values, cultural values, so that we can envelop that in a true understanding and a recognition that that's so critical to this goal plan that we're beginning to co-create with parents. The second section is from the Strengthening Families framework, where we begin to ask about critical supports. Everything from emotional to instrumental support, instrumental being, can you get somebody to help you transport you and your child to these visits? And so really understanding both concretely as well as conceptually, what are the supports that are in place, and do you have some? And the next section is in that the next subsection within that section is going into the different services and linkages. We want to build an ecosystem, understand the landscape of the supports and services that this family may be connected to or interested in. And from that, what we do is create a goal plan with the family driving that goal plan that has correlated action steps for the care team members, the pediatrician, the nurses, other care team members that might be involved, as well as the coach who is part of the care team, to help continue to support that plan longitudinally, with the parent continuing to iterate and update it as needed. And so that I would offer that as like a very concrete document that is in the EHR we're really excited about. That was quite the mountain to move.
Still moving it.
And we're still moving it. Lots of conversations, lots of relationship building, and we're so excited that the parent leaders themselves are driving this. Do you want to share more about the parent leaders?
Yeah, definitely. Thank you,
Yeah.
Dr. Holguin. So we have, as Dr. Holguin mentioned, we've established a parent leader group that concretizes, right, the role of parent leaders that we've tried to hold fidelity to from the beginning of the program, ever since we did that initial survey in the waiting area and went straight to parents and asked them, are you interested in these services? What other services would you like to see to support your financial health in the clinical visit? Ever since that time, we've been holding discussions and listening sessions with families to iterate and say, is this working? Is this not working? And what can we do better? So now we're really lucky to be able to actually concretize that and have a wonderful group of parent leaders who are meeting regularly to provide input, leadership, and a stable voice within the program leadership for to address exactly that.
And getting paid.
And
so
getting
we
paid.
value their time, getting paid. So we value their time, and they are truly equitably represented as co-decision makers in transforming our care model.
Critical piece. Yeah,
Yes.
thank you.
That's wonderful. It's very helpful to talk about the practical implementation of really important core values. So thank you for what you're doing there. I want to take just a second to talk also about another really exciting program underway in California in RCT that is near and dear to my heart, and it's a bit of a segue to our next question. But the Oakland Promise Brilliant Baby Program is partnering with the Bridge at NORC and UCSF Benioff Children's Hospital Oakland to implement a randomized controlled trial that's evaluating the impact of funding college savings accounts for Medicaid eligible babies, seated with $500 and offering financial coaching to their parents. And although there are lots of ways a parent in Oakland can enroll their baby into Brilliant Baby, one of the really critical and exciting challenges through that medical home. And so in partnership with Oakland Children's Hospital Claremont Clinic, This study the most recent report is assessing the impact on parents' behavior and their attitudes about a year and a half after their little one got their college account and they were able to participate in the program, children about 18 months of age. And similar to what this research has found is that parents in the intervention group have higher expectations for their children's educational attainment. They feel less stressed and they're scoring higher on measures of financial well-being. And interestingly, the moms are more likely to participate in WIC. So I think it's super exciting that there is a body of research building that is looking at this very, very critical moment and pathway to support families through their medical home. So to that end, I wonder if Monique and Adam, you could talk about how this UCLA LIFT partnership is helping to change the national landscape of health wealth interventions in clinical care and beyond.
You want to kick us off?
Sure. So thank you, Amanda, for mentioning that. As you know, as makes sense, right? As I hope folks who are engaging in this conversation can imagine, there's a lot of interest around the country within health systems, from folks who know financial capability services and know the health impacts of financial stability, in developing a community nationally that can support this medical financial partnership work. And so there have been, over the last decade or so, efforts to try and bring that community together in small ways. And we're very actively right now developing partnerships through national collaboratives and through other routes like this, like these conversations today, to identify, who's interested in this space, who wants to stay connected to the conversations, and to move the field forward really in a way that's coordinated. I'll mention one national collaborative that we're a part of that isn't specifically, naming medical financial partnerships in its kind of core aims, but has been really excited about the work that we're doing. There's a national collaborative called the Pediatric Supporting Parents Collaborative that we are a part of, that is interested in identifying leading practices nationally within healthcare settings for, as the name implies, supporting parents, across all dimensions of family life, and specifically in terms of early relational health and children's social emotional development. And you can't really talk about early relational health and social emotional development if you're not talking about financial stability for families. So we have really been, appreciative of the fact that we've brought that to the fore in the conversations through this collaborative that we're part of. We're one of the sites nationally that is taking part in the collaborative, and it's gaining a lot of traction. Right, this makes sense to people when we name the health wealth connections and talk about what we can do to directly intervene for families in clinical spaces to address upstream determinants of health. So we're excited to continue those conversations and really welcome, further discussions and conversation with any of you on today's call who want to talk more and think about what might be possible in your neck of the woods. Anything to add to that?
I would just add, just appreciative of, being able to continue to nurture pre-existing relationships and build out new ones, strengthen those new relationships through the Pediatric Supporting Parents Grant. Both Allie and Adam and I have been able to really foster that conversation that has been needed for so long to widen and deepen the conversation and name the structural drivers that are getting in the way of promoting early relational health, and really use the health wealth intervention to be able to be a driver in promoting early relational health. And so we're really excited to continue these conversations and work with folks in the Bay who happen to also be a proof point community within the Pediatric Supporting Parents Grant. So we're very familiar with the work and really appreciate you naming the impact that it's having already. It's very exciting. We're also thinking about new ways with this coalition building, new ways and new interventions. So yes, resilience coaching, that will continue to be a main driver in our work. It is the heart and soul of what we do. And we're thinking about new ways to really support the fullness of all of the families coming into both healthcare spaces and beyond, addressing, you had named public benefits as an anti-poverty tool, and getting connected to people, to getting connected to core benefits that promote health and well-being over time. We're building out tools and working with other stakeholders to really support that type of work, and through digital health tools. That if we had more time, we'd share. I want to also just name there's questions in the chat too. So
yep, there's some coming through. I want to give Allie just a minute to talk about the other side of the partnership, because the financial coaching field is a big field, national work. You're at the vanguard of pivoting financial coaching into a medical setting, a medical home.
Mm-hmm.
You could just talk about the shifts in that side of the partnership, and in the field broadly. We're going to jump next into our questions.
Yeah, thanks, Amanda. And I can keep it somewhat brief so we can get to some questions. But I think the way that Lyft is really thinking about this is pivoting, using our 25 plus years of direct service to be an innovation hub, right? To inform technical assistance partnerships to be able to bring to bear across the entire United States opportunities to infuse Lyft's financial economic mobility coaching into key systems, so that we're not only reaching the thousands, but the millions who are impacted by the issue of poverty. So that includes pediatric healthcare spaces, it includes community college spaces, it includes government systems, it includes early childcare spaces. And the way that we're doing that is marrying our expertise in coaching and financial economic mobility with the leadership of those key sectors to reach scale. Continuing to keep that intersectional lens, right? That we can bring holistic, trauma-informed strengths and asset-based approaches to create systems of care that are rooted in dignity and respect and trust. But then the last thing I would say is also it's about shifting in practice and behavior. It's about deeply listening to those partners and systems, that one size doesn't fit all, right? But to really foster those relationships, understand the needs in each of those settings, understand the staffing models, including everything in the healthcare space from the patient flow and journey to adapt, right? How the model can actually fit in a new setting, and weave our programming in authentic ways that work for each of those spaces. So really it's about being adaptable and doing deep listening, relationship building, and really making sure we're rooting it in the way that we're showing up and bringing coaching to bear in those systems.
Thank you. Thanks so much. I am going to pivot to some of our questions from our participants. Here is one. How do you manage expectations with families that don't have enough income to meet day-to-day needs? In particular, do you work with parents who are undocumented, who have undocumented immigration status that may be limited in their employment opportunities and eligibility for public benefits? Who would like to take that one?
Sure. So,
Go ahead.
Sure. Thank you for the question. And really appreciate just this time to be able to connect with everyone. Yes, we do. And thank you for naming it. So the LA County's Department of Health Services is the largest municipal health system in the west side of the country. Mm-hmm. And so we see a large swath of families, and we serve families who are primarily Medicaid eligible or on Medicaid, meaning that they're impacted by the driver of poverty. And so we're working with families irrespective of their insurance status too. Mm-hmm. So we often see families, we do not ask directly, but we often see families who are undocumented. Through that trust and relationship with the coach, we have come to find that many of our families will name their documentation status and the barriers that come along with it. And this is where key partnerships and relationships really come to bear. We work very closely with our community partners. We work very closely with internal partners, including the medical legal partnership, pro bono legal services that are offered for our families that can really help support some of the legal barriers that get in the way of really vital interventions and resources like public benefits attainment and continued support services for these families. So yes, anything else you add there?
Yeah, no, go ahead, Ali.
I was just going to add that similarly at Lyft, we're really about serving all families, which means including all families, regardless of documentation status and legal rights to work. So, and in fact, it's actually, I think, a driving force for us that if we can do that well, we can serve all families well. And at Lyft LA, at least, we serve about half of our families do not have rights to work, legal rights to work. And it's really about leaning in even further and creating even more inclusive pathways and opportunities for financial stability and mobility for them, including we've developed things like our entrepreneurship program and other ways to have different pathways forward. So definitely thinking about that, including giving direct cash assistance. So would just echo what Monique has shared already.
Thank you. Okay, we have time for one more question. And the question is, do you come across families receiving similar services such as evidence-based home visiting, healthy families, parents as teachers, nurse-family partnership? And what have you done to sort of meet with those national offices, or have you, or talking about partnerships? So many similarities is the observation from the participant listener.
Yeah, thanks for calling that out. I'll share that while we absolutely, come across families that are enrolled in other programs, it's not as common as you'd hope, and in LA County and other places, there's a patchwork of programs and services, and the unfortunate reality is that those programs don't reach nearly enough families, or nearly as many families as could benefit from them. And so while yes, a handful of our families may already be connected to those programs, much of our work is focused around figuring out, well, for the families that aren't already connected to those programs, how can we make sure that they're supported and connecting to programs that they are eligible for, and coordinate, right, and make sure that we're coordinating very consciously to understand how we can support those families in the context of the patchwork of programs that they may already be connected to, so that we're not duplicating services and we're complementing. So that's a big part of why the tailored relationship that the coach is able to have with families is key, because this is not a transactional program. This is a program that is relational and individualized. And so we can accommodate that complexity with families receiving multiple services from multiple agencies, and figure out, well, okay, how can we still be of help? We would welcome conversations with national partners like those, and have begun some conversations with other programs that are similar. So if there's any interest, we'd be happy to follow up. Sorry, man.
So much. I just want to hand it to Ali with her last 2 minutes to bring us home.
Yeah, and thanks, Amanda. And just to add to that, I saw Araceli, my colleague, chime in here as well to that question, but we've actually begun some conversations around home visitation programs to be thinking about building knowledge capital and bringing technical assistance to that workforce to be able to integrate financial coaching techniques and programming to that space into the family's home. So I want to be mindful of time and really just want to end with gratitude, deep gratitude for this conversation. Thank you again to my dear friends, Dr. Shikadance and Dr. Holguin, for this beautiful presentation on the amazing work that you've been doing at Harbor and all of you through the Medical Financial Partnership and the incredible study results. And Amanda, thank you for helping to bring us along through this conversation. Thank you for the deep work that you yourself have been leading on through the state of California, and bringing your lens to this conversation. We will share the Pediatrics Journal article after this with some follow-up materials for those interested. And many of you here today are working on economic mobility or place-based interventions and multi-pronged approaches to breaking the cycle of poverty so that families can thrive. Many of you are working in the healthcare space. So we want to make sure that we bring back learnings from this, hopefully to your work, and find it valuable. Really grateful to everyone for being here today and joining us. If you're interested in reaching out, and Alex, if you can pull up a slide, but if you're interested in reaching out to any of our presenters, I highly recommend it. Please leverage their contact information so you can learn more about ways that we can be collaborating and partnering and bringing economic mobility coaching and these incredible healthcare interventions to your location and to your body of work. You're going to see a poll that will pop up on your screens, just so you know. And the hope is that you can let us know if you want some more information on partnering with Lyft on TA services, or if you want to partner and learn more with Dr. Shikadance and Dr. Holguin on medical financial partnerships, and we'll be sure to be in touch. So please help us reach out to you. And thank you again for all of your time, for your questions. We're really, really grateful. So thank you all. Bye, everyone.
Everybody, we did it. What was that, Amanda?